Right, so what's the difference between incidence and prevalence? Incidence is new cases. So the incidence proportion are the new cases over the population at risk at the start. That's your incidence proportion, okay? You also have incidence rate, which would be the same thing of new cases but taken over person time, all right? Or person years, okay? What it tells you how fast the disease is occurring, all right? It's useful for studying risk factors and causal relationships. Then we have prevalence. Prevalence are all the cases, the new ones plus the existing ones. So you can get point prevalence, which are the existing cases at a specific time over the total population, or you can get a period prevalence, which are all cases during a period over the total population. And this tells you how widespread a disease is right now. Useful for assessing healthcare burden. So there's one point about incidence that I want to stress is that incidence is calculated by the new cases over the population at risk of being a new case. And I'll give you an example of this. Let's say you have a town that has 10,000 IV drug abusers and 1,000 of those IV drug abusers have hepatitis C. Let's say over a span of 1 year, you have 100 new cases of hepatitis C. The question is, what is the incidence rate now? So you're not going to look at the incidence rate within the 1,000 people that have hepatitis C. They already have it, right? You're going to look at the incidence rate amongst the population that does not have hepatitis C but is susceptible to getting it. The IV drug abusers, right? So 10,000 of them in total, 1,000 of them already have hepatitis C, which means 9,000 of them are still at risk of obtaining hepatitis C. So therefore, you're going to look at the new cases, 100 over 9,000. Here are some other specific measures of disease occurrence. So one of them is crude mortality rate. So this is going to be the total number of deaths by the total population size. We also have cause-specific mortality rate, which is the same idea. It's just death from a particular disease divided by the total population size. Then we have case fatality rate, which are the number of deaths from a specific disease by the number of people affected by that disease. So all the number of cases are in the denominator, and then the amount of people that have died from those cases of that specific disease are in the numerator. Next, we have the standardized mortality ratio. So this is the observed number of deaths divided by the expected number of deaths. Okay, so if you have a standardized mortality ratio of 2, it tells you that the observed mortality in that particular group is twice as high as what you expected. What you expected is usually the general population. Then we have attack rate. So this is a measure of incidence usually used in infectious disease epidemiology, and it's the number of patients with the disease divided by the total population at risk. Now, this is kind of similar to incidence rate, but the difference is this. When you're calculating the incidence rate, you are calculating the amount of new cases per person time, right? There's a specific time frame that you use as units in the denominator. For the attack rate, there is no explicit mentioning of a time period. Although there is a time period, it is very short and well defined. It is the time period of that outbreak, okay? And it is actually not a rate, it's actually a proportion, it's a risk, because it is the number of new cases over the number of the population at risk, all right? Which is not person years as it is in incidence, okay? Next, we have maternal mortality rate, which is the number of maternal deaths divided by the number of live births. And then there is the crude birth rate, which is the number of live births divided by the total population size. Let's talk about osteochondroma. So this is the most common benign bone tumor, and it is going to be a hard, palpable mass that arises from the long bone near a joint. So it's usually going to happen near the knee. Now, it's usually painless. The only time it can cause pain is if the patient has trauma to the area or if there's compression to neurovascular structures. When you do an X-ray, what you're going to see is a bony spur, and the bony spur is going to be at the metaphysis, but it's going to be pointing away from the epiphysis. What you'll also see is that the medullary and cortical bone of the medullary or cortical part of this osteochondroma is continuous with the adjacent bone that it's attached to. Now, what do we do for this situation? We do nothing. We do nothing. So let the person grow, let their skeleton become mature, and there is very low risk of complications such as pathologic fracture or malignant transformation. So we just observe. You can tell if it is a sporadic condition versus a hereditary condition based on the number of lesions. Usually people have one single lesion when it is sporadic. If it is hereditary, they will have multiple lesions. Let's compare this to other bone tumors that you may find in adolescence, primary bone tumors. So we have Ewing sarcoma. Ewing sarcoma is going to be a single tender soft tissue mass, and it's usually demonstrates itself on x-ray as a lytic lesion deeper in the bone with a multi-layer periosteal reaction. The other thing we have to worry about is osteosarcoma. Osteosarcoma is going to be ill-defined. It's going to be more so on the surface of the bone, and it is going to have an aggressive periosteal reaction known as the sunburst sign or the Codman triangle. Let's talk about some other kinds of bone tumors. So bone tumors all around can be classified based on their location relative to the epiphysis, diaphysis, or metaphysis. So let's talk about the epiphyseal bone tumors. The first one is giant cell tumor of bone. So this usually happens in people who have already developed skeletal maturity, so anywhere between the ages of 20 to 40. Most commonly occurs at the epiphyses of the distal femur and proximal tibia. And you're going to have localized pain, swelling, stiffness, pathologic fracture is common, and range of motion will be affected in the joint, okay? The morphology of the bone is going to change a lot, okay? So this is going to definitely affect joint motion, and we're going to see this on the radiograph. So the radiograph is going to reveal eccentric, expansive lytic lesions with a soap bubble appearance. I definitely recommend looking this up. It's pretty interesting to look at. It literally looks like soap bubbles. And that's going to be x-ray. You may have to do an MRI to evaluate the extent of the soft tissue involvement. When you do pathology is going to show multinucleated osteoclast-like giant cells interspersed with mononuclear stromal cells. Okay, so you're going to have these huge cells with a lot of nuclei that are tightly packed together, interspersed with a bunch of mononuclear stromal cells. The stromal cells overexpress rank L, and this is what induces activation and differentiation of osteoclasts. And here we basically have osteoclasts that have gone haywire. Management, surgery. Surgery is first line therapy. So you're going to excise the lesion and reconstruct the bone. For unresectable tumors, you can consider denosumab, which is a monoclonal antibody that inhibits rank L, which targets osteoclast activation. Prognosis is generally good. Okay, rarely is there malignant transformation or pulmonary metastases, which is possible. The risk for local recurrence is high, especially if there is an incomplete excision. Next, we have chondroblastoma, which is a benign cartilage-producing epiphyseal tumor. This usually occurs in adolescents aged 10 to 21, more commonly in male patients. The location is going to be the epiphysis of the distal femur, proximal tibia, or proximal humerus. Radiographs are going to show a radiolucent lesion with a thin sclerotic border that may cross the physis. Calcifications may be present. This is going to be kind of small, not too big. Radiolucent lesion involving the epiphysis. Yeah, it's going to be the cartilage lighting it up. Pathology, you're going to see immature chondroblasts, osteoblasts-like giant cells, chondroid matrix. Management, surgery with reconstruction. The surgery is the curettage. Prognosis is generally favorable. If the physis is involved, and since this is in people that have not yet reached skeletal maturity, it can lead to growth arrest, and joint involvement can lead to arthritis. Next, you have the diaphyseal bone tumors, of which Ewing sarcoma is one that I mentioned. I'm just going to talk about it in a little bit more detail. So it is the second most common malignant bone tumor in children and adolescents. The first one is osteosarcoma. Peak age range is 10 to 15 years. It affects the diaphyses of the long bones. It can also affect the pelvis and the axial skeleton. At presentation, there's going to be pain that is often worse at night. Radiographs are going to show a central lytic lesion with a mottled or moth-eaten appearance that infiltrates the bony cortex and adjacent soft tissue. There's also an associated periosteal reaction that may look as onion skinning. Pathology, histopathology is going to show sheets of uniform small round blue cells with scant cytoplasm separated by fibrous septa and patches of necrosis. Treatment is chemotherapy with local control via surgical resection and or radiation therapy. Prognosis, the 5-year survival rate is approximately 70% in patients with localized disease and approximately 33% for patients with metastatic disease at the time of diagnosis. It often metastasizes to the lungs. That will usually manifest itself as hemoptysis. The next diaphyseal bone tumor is osteoid osteoma. Right, most commonly occurs in adolescent boys. Occurs in the lower extremities, particularly the proximal femur and tibia, and the spine can also be affected. It is also pain that is worse at night. It is pain that is relieved by NSAIDs. Most patients have no systemic symptoms or focal examination findings. When you do the radiograph, you'll see a small round lucency with sclerotic margins. This kind of sounds like chondroblastoma, except when you look at this, the lesion is going to look like it's deeper in the bone. Okay, whereas the chondroblastoma seem to be a little bit more superficial. So it says central ossification may be present on the lesion. Pathology shows a central nidus with osteoblast and an osteoid matrix. Management, NSAIDs are prescribed and seroradiographs are performed to monitor the growth. Surgical resection may be considered if patients cannot tolerate long-term NSAID use. Prognosis, many times it spontaneously resolves on its own within years of the diagnosis. So this is the reason why we're only going to do surgical resection if it gets big. Next, let's talk about the metaphyseal bone tumors. And the first one is going to be osteosarcoma. So I mentioned osteosarcoma before. Let's talk about it in a bit more detail. So this is going to be the most common primary malignant bone tumor in children and adolescents, and occurs as in a bimodal distribution, ages less than 25 or greater than 50. Okay, or greater than 50. It commonly occurs at the metaphyses of the distal femur, proximal tibia, and proximal humerus. Clinical presentation, we have chronic localized pain that is dull and progressive over weeks to months. Physical examination will show tenderness and swelling on the soft tissue close to the mass. And depending on the location, you can see decreased range of motion or abnormal gait. Imaging, radiographs will show an ill-defined lesion with a mixture of radiolucent and radiodense areas within the metaphysis of a long bone, often with a sunburst periosteal reaction that is characterized by ossification of fragmented fibers perpendicular to the bone. Pathology is going to show you malignant cells that resemble osteoblasts, which vary in size. This is known as pleomorphic, with atypical nuclei and irregular lace-like osteoid. Interesting. Management involves chemotherapy and surgical resection. Prognosis depends on where we found it at the stage of presentation. So if you have localized disease, it's a favorable outcome. Those with metastases have a poor prognosis. Next, let's talk about fibrosarcoma, malignant bone tumor which arises from the metaphysis and arises from fibrous connective tissue of the metaphysis. It is rare, most commonly affects middle-aged adults. Long bones, particularly the femur, tibia, and humerus. There may be pathologic fracture. history of pre-existing bone lesions from irradiated tissue. Radiographs show a localized osteolytic lesion that infiltrates the cortex and adjacent soft tissues with minimal periosteal reaction. Histopathology shows spindle cells, which are described as cells with scant cytoplasm and elongated hyperchromatic nuclei arranged in a herringbone pattern. Interesting. Management. Treatment involves chemotherapy and surgical resection. Prognosis is unfavorable due to the high risk of recurrence and metastasis. Next, we have a unicameral bone cyst, a benign fluid-filled bone cyst. Okay. Most commonly occurs in skeletally immature children and adolescents. Commonly develops in the metaphysis of long bones, especially the humerus and the femur. It's usually found incidentally on imaging, and rarely present with pain or pathologic fracture. Radiograph shows a well-defined lucency with a thin sclerotic margin. MRI shows a homogeneous fluid-filled lesion within the bone. Spontaneous resolution occurs in most cases, so the prognosis is favorable. We will observe with serial radiographs until we see spontaneous resolution, which typically occurs after skeletal maturity. Next, we have osteochondroma. So, benign metaphyseal bone tumor. Well, that's the first one I talked about in the beginning. I'm not going to talk about that again. It's metaphyseal bone tumor. Next, we have chondrosarcoma. Malignant cartilage-producing bone tumor. Most commonly occurs in adults greater than 40. Affects the metaphysis of long bones, particularly the humerus, femur, and sometimes the pelvis. There's going to be insidious and progressive pain for months to years prior to the diagnosis. Pathologic fractures may occur. Radiographs will show radiolucent and radiodense areas with intralesional calcifications in a ring and arc pattern. Okay, this is for chondrosarcoma. Pathology is going to have atypical chondrocytes with abundant chondroid matrix. Management is going to be surgical resection. Chemotherapy may be considered in patients in which it's resectable, aka unresectable, aka metastatic disease. Prognosis is favorable if we achieve a full resection. Next, let's talk about enchondroma. Enchondroma is a benign metaphyseal cartilage-producing tumor. Occurs mostly in adolescents and young adults. Develops in the metaphysis of long bones, particularly the hand, humerus, and femur. Most patients are asymptomatic, found incidentally, present with pain due to pathologic fracture, gross deformity, or leg length discrepancy. Radiograph will show a well-circumscribed lesion with central lucency, central calcifications, and sclerotic margins may be present. Histopathology is going to show chondrocytes with abundant chondroid and punctate calcifications. Surgical resection is performed if there are risk factors for pathologic fracture, such as large size and location in a weight-bearing bone. Prognosis is spontaneous resolution in most patients. There are rare complications that include local recurrence and malignant transformation to chondrosarcoma. Next, we have a non-ossifying fibroma, which is a benign metaphyseal developmental defect characterized by fibrous connective tissue. This most commonly occurs in adolescents and young adults. Most commonly develops in the metaphyses of long bones, particularly the femur and tibia. Most patients are asymptomatic. It is found incidentally, rarely present with pathologic fracture. Radiographs show a well-circumscribed lytic lesion. Histopathology shows fibrous connective tissue with no bone. Management involves observation. Surgical resection if there are risk factors for pathologic fracture, as we mentioned before. Spontaneous resolution usually occurs in most patients. Complications include local recurrence and malignant transformation to chondrosarcoma. Vulvar cancer. The risk factor for vulvar cancer are persistent HPV infection and chronic inflammation. The chronic inflammation, well, these are actually the analogies, I should say. So the chronic inflammation is a lot of times due to lichen sclerosis, especially in postmenopausal women. And when we see lichen sclerosis, the first thing we're going to do is to give topical corticosteroids. But if that doesn't work, and it persists, it can start to transform into a malignancy. And then at that point, if the lesions look atypical or if they just haven't improved at all with the corticosteroids, then we're going to do a vulvar biopsy. Okay, we're going to do a vulvar biopsy. Risk factors are tobacco use, vulvar lichen sclerosis, immunodeficiency, prior cervical cancer, or vulvar/cervical intraepithelial neoplasia. The patient will present with dyspareunia, vulvar pruritus, vulvar plaque/ulcer, may have abnormal bleeding, and you make the diagnosis with biopsy. It's a throwback to like step 1 days. We have a tuberous sclerosis complex. Autosomal dominant inherited clinical features. The main ones are neurologic, such as epilepsy. So the kid is most likely going to present with seizures, and when they come in, they're going to have this constellation of symptoms that's going to give it away. And one of them is some dermatologic manifestations, such as ash leaf spots or angiofibromas of the malar region or shagreen patches. These dermatologic findings may be described as hypopigmented lesions. What are you going to do with this patient? Well, if they come in with seizures, you want to confirm that, in fact, they're having seizures. So you can do an electroencephalogram. The seizures may get worse. The person is going to have intellectual disability throughout their life, may have autism and behavioral disorders. In terms of cardiovascular issues, you will suspect rhabdomyomas. Very rare cancer, right? In terms of renal, you may find angiomyolipomas, right? So it's all neurologic, dermatologic, cardiovascular with rhabdomyomas, and renal with angiomyolipomas. What do? Surveillance for tumor screening. You do regular skin and eye examinations, serial MRIs of the brain and kidney, do baseline echocardiography, and serial ECGs. The most likely cause of death in these patients is severe epilepsy. If you do an ultrasound on a first trimester mother and you see that there is how is this described? A crescent-shaped hypoechoic area between the gestational sac and the uterus. This is most likely a hematoma, subchorionic hematoma. What are you going to do in this case? You're going to do expectant management. You're not going to do anything, okay? But there are some things you need to be aware of with this particular person. So first thing are risk factors for this to even happen in the first place are infertility treatment, anticoagulation, uterine anomalies, and recurrent pregnancy loss. What are possible complications that can happen from a subchorionic hematoma? You can have spontaneous abortion. You can have an abrupted placenta. You can have preterm premature rupture of membranes and preterm delivery. So have all these things in your mind. Now, are these things common to happen? No. Majority of patients with subchorionic hematomas have an uncomplicated pregnancy. Let's view the uses and risks of some of the most common herbal medications. So we have ginkgo biloba, which is used for memory enhancement. Adverse effect is increased bleeding risk. We have ginseng, which is also used for improved mental performance. Its adverse effect is also increased bleeding risk. We have saw palmetto, which is used for benign prostatic hyperplasia. Adverse effect of mild stomach discomfort. We have black cohosh, which is used for menopausal symptoms such as hot flashes and vaginal dryness. The adverse effect is hepatic injury. We have St. John's wort, which the uses are depression and insomnia. Its adverse effects may be drug interactions with antidepressants, anticoagulants, and digoxin. It may also precipitate a hypertensive crisis. We have kava, which is used for anxiety and insomnia. Adverse effect is liver damage. We have licorice, which is used for stomach ulcers and bronchitis/viral infections. Its adverse effect is hypertension and hypokalemia. We have echinacea, which is treatment and prevention of cold and flu. Adverse effects include allergic reaction and dyspepsia. We have ephedra, which is used to treat colds and flus. It's also used for weight loss and improving athletic performance. Adverse effects include hypertension, arrhythmia, MI, sudden death, stroke, and seizure. If you are going to use herbs, go and consult a legit herbalist. Acute onset of unilateral facial paralysis can be due to two main things. One is idiopathic facial nerve palsy, also known as Bell palsy. And the other one is due to Lyme's disease, right? So the treatment is completely different for both of them. With Bell's palsy, you want to give oral corticosteroids as soon as possible, as soon as you can after the onset, ideally within 3 days. For Lyme disease, facial paralysis, you do not want to give corticosteroids. Corticosteroids will worsen the infection in this situation. So if you suspect Lyme disease, what you want to do is you want to do a Lyme serology first before you consider any kind of treatment. If the Lyme serology comes out positive, then you treat with doxycycline. If it comes out negative, then we can say that this is idiopathic facial nerve palsy, aka Bell's palsy, and we treat with corticosteroids, oral corticosteroids.